Can
you hear me?
There's a computer glitch here with the internet connection or something mysterious in that realm. We're going to proceed. Carolyn is going to type the questions for me, and I'm going to answer them. And I think that the program that we're using is trying to correct Carolyn's connection. If anyone's in the chat, can you tell us if you can see us both and hear me? Yes, if you happen to be viewing this, please let us know. You can. Yes, can you, Facebook user? Can you see us both?
Can you hear me?
Yes to both. And Carolyn, are you going to type the first question so I can see it? All right. So here's the question from Carolyn. I will not be able to replicate her voice, but I'm going to read it. Since the 24-hour urine shows us what's happening during the 24-hour period, is it not more important to test when a woman is symptomatic? Well, it's not necessary or valuable to test when a woman's symptomatic. And we test 100% of the women, but we don't test them in the beginning. And we usually wait until a woman's has been in her treatment program for 2, 3, 4 months. And we choose the time to test when she says, I feel good, I feel great, I feel myself again. That's when we test with the 24-hour urine hormone test. I see no value in testing at any other time because hormones are so powerful that absence of them in at least 75% of the cases, women have symptoms of hormone insufficiency. For example, most women who have low estrogen get some kind of vasomotor issue called hot flashes or warm rushes. And they can wake up in the middle of the night in a sweat. And these phenomena are caused by low estrogen, and there would be no need to test her. Well, let me back up a bit. When a woman no longer is having periods, her ovaries are putting out close to zero and ultimately zero estrogen and zero ovaries progesterone. Yes, a little progesterone comes from the adrenal glands, but zero comes from the ovaries. The ovaries stop doing it. And when that happens, and a woman comes into a healthcare provider's office and says, I'm not having periods, we could test her. In fact, when I first started working with women in menopause, I did test them. And then I learned very quickly that they weren't having periods, their hormone levels were super low, and the woman had the privilege of paying $300 for me to be able to tell her what I already knew, that her hormones were super low. She wasn't having periods. There's no reason to test a woman's hormone levels if she's not having periods. Well, let's back up a bit. Let's talk about the perimenopause. The woman's still having periods. They may be regular, they may be irregular, but they're starting to get symptoms of hormonal insufficiency. They could have mood changes. They could have difficulty sleeping. They could have anxiety and depression that they just don't really understand. It doesn't make sense with their life. And they can even be having warm rushes, but they can still be having periods. They can have symptoms of estrogen insufficiency or progesterone insufficiency, or even testosterone deficiency. However, as the ovaries start to decline in function, the brain, the pituitary, realizes this, realize that these hormones are lower than they've ever been, and it has a remedy. The pituitary gland, for example, can shoot out some extra stimulating hormone. It can stimulate those ovaries, and it puts out extra stimulating hormones, and you get a rise when the pituitary puts out that stimulating hormone. You can get a rise in estrogen. You can get a rise in estrogen, for example, higher than a woman usually does in a regularly menstruating early life. In fact, it's very erratic, because this goes back and forth, because although the pituitary gland can stimulate the ovaries short term, the ovaries are losing it, and they can't keep up with the high production. So instead of having these nice smooth outputs of estrogen over the course of the month, you get these erratic, higher peaks and lower troughs than ever before. But what it all adds up to in the month is not enough estrogen. So to test in the perimenopause is perilous. How do I know this? I saw a woman in the perimenopause many, many years ago. She was having hot flashes. She was waking up in the middle of the night. I knew she was low in estrogen, but I wanted to test her. And I tested her, and her estrogen levels were high because I caught her on one of those high peak days. I know she needs estrogen, so I say to her while she's looking at her laboratory report of high estrogens, "Hey, I want to treat you with estrogens." And she looks at me like I'm out of my mind. Why in the world would I test her and get a test that shows high estrogens and then want to give her estrogens? Well, that was the last time I checked a woman in the perimenopause. So what does that add up to? Don't test a woman who's not having periods anymore. You're just going to learn that she's got super low estrogen, super low progesterone, and she may or may not have low testosterone, but she soon will have low testosterone. So you're wasting her money. And don't test a woman in the perimenopause, because if you test her on the wrong day, a day when she's getting stimulation from that pituitary, you could get high levels when really over the course of the month she's really running quite low. So you'll confuse yourself and you'll confuse the patient. So moral of the story, test 100% of the women, but there's no need to test a woman until she says, "I'm feeling great." Now, are there exceptions to this? Yes, very, very rarely, once a year, once every couple of years. We'll be going along in the process of trying to determine right dose, and it just won't be we just won't feel like we're getting it right. So there's occasionally, in some mysterious, challenging cases, and they do exist, I will test before a woman says, "I feel great." So that's about what I have to say about testing a woman.
Okay.
And then here's the next question. Since I can't talk to Carolyn, maybe you can see Carolyn.
Maybe you
Carolyn,
guys
how about if you
move
move your lips when I ask the question? We'll pretend it's you talking. Here we go.
Okay.
So then you do not, just kidding. So then you do not, or you do give hormones as you would to a woman in perimenopause. What does one do? Take nothing? Oh no. A woman in perimenopause, it's an ideal time to start treatment. Because if a woman has symptoms of low estrogen, hot flashes, warm rushes, low progesterone, can't sleep, anxiety, depression, it's an ideal time to treat her. Her hormone levels are lower than they were when she was 20 plus or minus 2 years. This is when a woman's output of the ovaries is the absolute maximum. Then gradual decline. So if the woman's getting decline and she's getting symptoms, what we do is we come in with smaller doses, gradually increase until the symptoms are alleviated. So we augment the production of the ovary so that a woman feels good. So she sleeps, her mood is good, she's protecting, what she doesn't know is she's protecting her bones, her arteries, her vagina. So yes, we definitely treat a woman in the perimenopause. When a woman starts having symptoms, we treat. And if you want to know what those symptoms are, Carolyn on her Facebook Live Ins and Outs of Menopause page offers a free PDF copy of our book, Happy, Healthy Hormones. And you can download that and you can learn a lot about what's happening. You'll relate to it. If you're in the perimenopause or you're in menopause, this is going to make a lot of sense to you. So the next question is here.
Got it.
Testosterone. Have been taking testosterone now 3 weeks via injections, but cannot get testosterone up. I do not know what to do. Could this be SHBG? Should I get SHBG or wait? It is very confusing. Should I maybe change? What's going on here? When you're injecting testosterone, and my goodness gracious, I don't know if this is coming from a woman or a man. I'm going to assume it's coming from a woman.
Woman.
For one thing, I just see no need in the world for a woman to take testosterone injections. And if you are taking testosterone and the bottle says testosterone, you are getting testosterone. So you could be overshooting the amount of dosage your body actually needs and wants. I would immediately not, my recommendation would be take testosterone topically. My favorite is in organic oils. You can also do it in creams and gels, but do it topically. Don't try and take testosterone by injection if you're a woman. It's just so unnecessary to do that. And by injection, you get these super high peaks and then you get a rapid fall off. Whereas when you take something that you apply to your skin, it goes into your skin at a very nice rate, and it keeps, you can keep your levels up so that you only have to apply it once a day. And so something's wrong. You're asking about sex hormone binding globulin, but injecting testosterone and having it be interfered with sex hormone binding globulin, I don't get it. And I wouldn't approach it by, we always test sex hormone binding globulin with every woman, but it's so unlikely that sex hormone binding globulin is the culprit here. I would start all over. I would find a provider who knows how to prescribe this in organic oils or in creams or gels. I would do the initial process. In the menopause method, we have a very extensive process that begins by learning a heck of a lot about our patient, doing some initial blood tests that includes SHBG and thyroid. And then we start you right away in that first visit on Biest and progesterone, and very often testosterone and DHEA. Depends on if you have symptoms of testosterone deficiency, which so many women do, even in the perimenopause. So that may not be a satisfactory answer, but I just don't see any reason for a woman to be injecting testosterone, or a man for that matter. I take my testosterone every single day. And so there. Next question. There's a question from a Facebook user about any news on our Bright program. It's moving right along. There is a major team doing a rather prodigious effort to put the technology together. You'd think it'd be pretty simple for a physician or a nurse practitioner or a PA to transmit a prescription to the pharmacy, to the national pharmacist. it's moving along. We hope the beta test version is going to be ready in 2 to 4 weeks. And then as soon as we test it, and as soon as we take out the bugs, it should be ready for the public. And all of our providers who want access to it can have it. All right. I'm reading this question.
Sorry.
Next question. I'm getting menstrual migraines every month. They always come, and I become bedridden. Not irregular or erratic. I know many women who suffer same. Have you heard of this? And what can we do? Well, there's a lot of causes of migraines. And menstrual migraines is really one of those causes. And what they are is they relate to a rather dramatic lessening of the amount of estrogen and a rather dramatic fall of the estrogen. That will trigger the migraine in some women. And I really start believing in menstrual migraines when a woman has a medical history that when she was young and regularly menstruating, she didn't get migraines, but then she started developing migraines, and they seem to come periodic with the menstrual period, in the sense that they're coming at 1 or 2 times. They're coming when the estrogen falls. So the estrogen falls, of course, at the end of the menstrual month, drops way low. That triggers the period, part of what triggers the period. But it also takes a fall in mid-cycle, because how estrogen comes out is it comes out strong, and by day 12 it's at its peak, and then it drops, and then it rises again, and then falls. Now, and I'm not certain when this woman is having this periodic migraine, but when you are getting migraine headaches and they are timed with your period, you are definitely a wonderful candidate to do a trial of getting treated with estrogen. Biased is my recommendation. And what your job is, the same job that every woman has. It's to actually go shopping, do some research, find a healthcare provider who loves treating women in menopause with hormones, and ideally with compounded bioidentical hormones, and knows a lot, has gotten the training they need, and even has some experience or is getting mentored, so they can do this with excellence. Because you're someone that, well, like every woman, we want to be able to know how to address this. And what we would do is we would suspect that your estrogens are dropping. And what would we do? We would treat you with estrogen. And we'd give you the same amount every day. So if your levels that we suspect they're low, we'll start you with a gradual treatment, and we'll gradually increase those general body levels by treating you every day with a topical, well, in our case, organic oils base, or you can use creams or gels. We'll gradually increase that estrogen. And if the theory is correct that your migraine headaches are related to estrogen deficiency, you're going to feel better. You're not going to get them. That's the end point. Now we go further, and we describe this process in the book, Happy Healthy Hormones. We go further to help you, quote, dial in, end quote, the optimal dosages and balances of both biest, which is the estrogen, progesterone, and very often testosterone and DHEA. Sooner or later, everyone gets testosterone and DHEA. So it's an experiment. We suspect that you have menstrual migraines. They're most likely caused by the fall of estrogens. We replenish your estrogens, and if those headaches go away, bingo, our diagnosis was correct. And it is a common thing, and it's not that challenging a process. The biggest challenge for you is going to be finding a healthcare provider who's taken a special interest in prescribing compounded bioidentical hormones to women in menopause. And they have the education and they've got the tools. They'll know about this. They'll know how to guide you properly. All right. Can I explain biased? And why more estriol than estradiol? Many women keep coming using bias, saying it's too weak. All right, well, let me tell you a story of bias. A young woman's body puts out a hormone family called estrogens. It's really a hormone family. There is no hormone called estrogen. There's 3 major estrogens. The most potent one put out by the female ovary is called estradiol.
Yes.
Well, there's a second one that's almost as potent as estradiol. It's about 80% as potent as estradiol. It's called estrone.
Yes.
And there's more estrone than there is estradiol. If you test a young woman, there's about twice as much or a little more estrone than there is estradiol. And there's a third estrogen put out by a healthy young woman, and it's called estriol.
Yes.
It has an abbreviation E3. Estradiol is E2. Estrone is E1, just abbreviations. And lo and behold, estriol is weaker than the most potent estrogen.
Right.
Estradiol.
Right.
It's about an eighth as potent as estradiol. Right. But lo and behold, it's the most prevalent. There's more estriol in a young, healthy woman than there is the sum of estrone and estradiol. So God bless Dr. Jonathan Wright, who in the early 1980s said, if we're going to treat women with estrogen, first of all, let's use bioidentical estrogens. They're available. We can get that. And not only that, why invent a new woman? Or as Dr. Wright said, why don't we just copy nature and provide to a woman that we're treating with estrogens nature's formulation, which has more estriol in it than it has the sum of estradiol and estrone. Now, not only that, he also had encountered some research by a medical doctor who was a specialist in treating women with breast cancer, an oncologist who was actually working out of the University of Nebraska. This is Dr. Henry Lemon, and what Dr. Lemon discovered, he wanted to see if there was a difference in hormone profiles of young, healthy women and women who had breast cancer. So he did 24-hour urines. Oh, really? In the 1960s? Yeah. It is the gold standard. He did 24-hour urines on young, healthy women, and lo and behold, he found that there was more estriol than the sum of estrone and estradiol. In fact, there was 1.3 times as much on the average estriol as there was the sum of estrone and estradiol. And what he found in many women who had breast cancer, that there wasn't as much estriol. It was less estriol than there was the sum of estrone and estradiol. So cancer is very complex, and it's not based only on hormonology. But Dr. Wright said, why don't we just copy nature rather than invent a new woman? Well, that was radical, because women were being treated with Premarin primarily, horse urine-derived estrogens in a pill, dried out horse urine, had many estrogens in there, including 50% that a human female had never seen.
Well, they were horse urines.
And so that was being used. There was also oral estradiol was being used. Oral estradiol was present in birth control pills, but it was also being used in larger doses to treat women in menopause. And Dr. Wright also uncovered that it took more oral estradiol. You had to get the dosage higher because 80% of it was processed in the liver before it even made it to the body when you swallow a steroid hormone. So Dr. Wright said, whoa, let's get this closer to nature. Number one, let's not just prescribe pure estradiol, because that's not what a young woman is doing. Let's make a combination of estradiol plus estriol. And let's put that formula together so that when we do a 24-hour urine on these women, that their profile looks like a young, healthy woman with more estradiol than the sum of estrogen and estradiol. In order to do that, a lot of women need 80% estradiol and 20% estradiol. In fact, I would make a guess that 75% of women who start on 80% estradiol wind up on it. And a lot of women, they need a little more estradiol, 70% estradiol, 30% estradiol, or 40% estradiol, or even 50% estradiol. These are much less common, but we do find that. And how do we find it out? We find it out on 24-hour urine hormone testing. So when someone says biased is too weak, well, let me address that. I'm amazed at how many women I've seen that have already been treated with hormones that are on dosages that are too low. I mean, everyone was sort of contaminated by false information that you should take the lowest amount of hormone for the shortest amount of time. I don't know who in the world invented that crazy thing. You wouldn't take the lowest amount of penicillin for the shortest amount of time. If you had a strep throat, penicillin, ampicillin. You wouldn't take the lowest amount of blood pressure medication for the shortest amount of time. No, you would take the right amount that lowered your blood pressure, and you might take it until you found a way to heal your blood pressure. You take it for your whole life. Well, this was, of course, coming out of the scare of the Women's Health Initiative, but I'm not going to go there. The main thing is you need to get the right amount. And people commonly, and I don't know where this teaching is coming from, are prescribing biased dosages that are too low. So I'm not going to say it's from the biased. I'm saying it's from a biased formulation that doesn't have enough milligrams per milliliter in it. Because we are 30 years of using biased. I have been. And we're always successful with it. We never use pure estradiol. And what happens is we correlate this with the 24-hour urine hormone test, and we can pretty much replicate the ratio that a young woman has. Now, I want to go a little bit further because this is an important thing. That every single menstrual cycle, a woman goes through what's called in medicine proliferative phase. It's the first part of the cycle. You get proliferation of the lining of the endometrium that was shed in the previous period. You get a brand new formation of new cells lining the lining of the uterus, preparing for the possible fertilized egg to implant there. It's rich. And there's a tremendous amount of cell proliferation that goes on there. And if you don't get pregnant, you deproliferate. And those cells die, and they get shed in what's called the menstrual flow, the menstrual period. It's very bloody, but that's not the only thing that's coming out there. Some of the cells are coming out there too. Proliferative phase, building up for the lining to receive a fertilized egg, no fertilization, deproliferation. Well, oddly enough, or miraculously enough, or wildly enough, every single cycle a woman is preparing for possible breastfeeding. It begins that early. You get proliferation in the breasts. You get proliferation of breast glandular cells. You produce new breast glandular cells by cell division. And many women experience this. As their cycle goes on, they start getting fuller and fuller and fuller breasts. There's new cells in there. Cell division, proliferation. However, if you don't get pregnant, you deproliferate.
Right. So you go down.
The cells that were formed disappear by a wonderful named process called apoptosis. Those cells disappear. So when a woman is menstruating very often, her breast will get less full. And this repeats over and over again. Proliferation in the uterus, proliferation in the breast, deproliferation if there's no impregnation. Well, it turns out that in the late 90s, long before Dr. Lemon did his work and Dr. Wright proposed just copying nature, pretty radical, copy nature, duh. In the late 90s, they discovered estrogen receptor sites. They saw how estrogen works. You got the hormone estrogen, but it fits into receptor sites in the cells, actually in the nucleus of the cell. It's just extraordinary process there, and that's how it works. And there's two types of receptor sites. During the first half of the cycle, there's a receptor site that encourages proliferation. And if there's no impregnation, there's a different receptor site that when estrogen interacts with it, you get deproliferation. Two different types of receptor sites. Well, it turns out estradiol is the principal hormone that stimulates proliferation, and estriol is the principal hormone that stimulates deproliferation. We don't want endless proliferation. We don't want proliferation in a woman who's in her midlife and later. We don't need it. We can get very adequate and effective estrogen doses without getting the proliferation. So we always choose bias because it has estriol in it. And that estriol is the main encourager of deproliferation. That's what we want in a menopause woman. We want deproliferation. So, moral of the story, copy nature. Do biased. And listen, if the only thing you have is estradiol in a patch or a gel, it's going to do you some good. And if the only thing you had is Premarin, it'll do you some good. So the good news about hormones is there's a lot of different forms, and you can take them and that you can do decent work with all of them. But why not do state of the art? Why not do the most scientifically based, same molecule, same proportions? I always encourage compounded bioidentical hormones.
I agree. If you guys can hear me, I agree.
All right. Just the estradiol. There's an estradiol in the estradiol vaginal cream.
Yeah.
Is that it?
Yeah.
With a question mark?
Yeah.
Good stuff. Because as a woman is losing her estrogens, everything that's dependent on adequate estrogen starts slipping. And estrogen is crucial for the health of the vagina. So if you are having intercourse and it starts to get dry and painful and you need lubrication, your vagina is actually changing form. And that's because your estrogen is falling. So there's many women who enter midlife, and by the time they connect up with a medical care provider, they have some elements of vaginal change. And they're having painful intercourse, or they're having dry vagina, or they're getting recurrent urinary tract infections, bladder infections. And to give estradiol in a vaginal cream makes a lot of sense, to apply it directly to the vagina. It can facilitate and accelerate the healing of the vagina, and it will work.
Oh.
Sometimes it depends on how much vaginal atrophy there is. Sometimes I think in terms of 3 to 6 months of treatment with estrogen.
Yeah.
But sometimes it's quicker than that. It all depends on how much atrophy there is and how much time there's been with estrogen loss. Now, having said that, a lot of women who seek treatment are just at the beginning of vaginal change. They definitely need the estrogen, But we rely on the estrogen that we apply to the forearms, for example.
Mm-hmm.
We'll have a couple of drops, we'll put it on the forearm, da-da,
Rub
and
it
of course not with my coat on, and rub the forearms together. And, you know, women who have mild vaginal changes, they'll get better just by using their bias, for example, on their forearms. No problem. But sometimes we want to assist that process, the healing of the vagina. We want to accelerate it. So we'll ask a woman to put a drop or two of bias in her vagina, put it on her finger and insert it into her vagina. And, or, you know, there's other methods of delivery. There's suppositories, there's pills that you can put in the vagina, there's creams, there's gels. My favorite is the organic oils. But yes, there's times when we like to accelerate the process of vaginal healing by using an estradiol vaginal gel, or we use Biest. It turns out that estradiol is super good for the vagina. And
Okay.
back in the day, when I first started out, if we wanted to, we would rely upon the biased dose that a woman was applying to her arms, but we'd give a woman a certain daily dosage of estriol vaginal cream, not estradiol. We use estriol because it has special benefit for the vagina, and we wouldn't have to treat the woman very long with the estriol vaginal oils, for example, because the recovery is going to be fast enough that, and the recovery was also going to take place by raising her systemic levels of bias. So she didn't need to keep putting in her vagina on and on and on. Especially that's important for women who are having intercourse. You don't want to be passing on vaginal estradiol, which you will, because things linger in the vagina. It's an excellent absorptive surface, but things linger in there. We know that through testing. So we don't, especially for a woman who's having intercourse, we don't suggest that she keep on doing a vaginal estradiol. In fact, we use vaginal Biest, and if she's having intercourse, we won't rely on it. We'll rely on lubrication plus the bias that she's applying to her forearm twice a day.
Got
She'll
it.
recover. So it's always an individual thing. How much, where, when, but estrogen is crucial for the healing of the vagina, and there's lots of different ways to administer it,
Yeah.
and you want to take it for your whole life.
Got it. Got it.
All right, where should I go now? Last question. I am taking an oral estrogen pill, 0.5 milligram. My T4 and T3, though, are tanking, as is my estrogen. Have you seen this, and what can I do if you may? Well, there's an interesting relationship to estrogen and thyroid. And anyone who's being treated with estrogen or thyroid, we need to pay attention to both in the process of treatment. So if we're going to start a woman on estrogen, we're going to test her thyroid in the beginning, and we may want to test it 3 months, 6 months down the line, as its effectiveness may be blunted by the estrogen, and vice versa. So meanwhile, there's a relationship between thyroid and estrogen. It's not apparent in most every woman, but it is apparent in some clinically, meaning that a woman can feel that something's off. And so that's one of the places we look. Now, oral estrogen, if it was the only tool I had, I'd celebrate it. But it's not the only tool we have.
Right.
And I 100% recommend that you get treated by someone who really understands compounded bioidentical hormones, and you can be treated with Biest topically. We prefer the organic oils. It's also compoundable in creams and gels. That's the best way to administer estrogen. that oral estrogen pill is pure estradiol. And I was delighted to go into some detail about why we always include estriol. I haven't heard of a biased pill, but I still wouldn't want to do it, because when you swallow a steroid hormone like estrogen, it goes into your intestinal tract, and it goes from the intestinal tract directly to the liver. That's how it works. Well, the liver knows what to do. It's going to process it, and it processes it and then changes the nature of the original estrogen into something called metabolites. Those are not hormones. And you lose about 80 to 90% through what's called the first pass through the liver.
Yeah.
So you got to take elevated dosages. And estrogens in those high dosages, taken by mouth, they can promote the liver to produce two different types of proteins, one that enhance coagulation and another that enhance inflammation. Where did we first learn this? With the birth control pills. They have an oral estradiol in there. And there was a certain small percentage of women who took the birth control pills that got blood clots in their legs. And some of those women even had that blood clot break loose and go to their lungs, a pulmonary embolus. It was the oral estrogen part of that birth control pill that was the provocateur. It was a small number of women, and those women probably had an increased propensity to clot to begin with, but it definitely happened. And any physician or nurse practitioner who's seeing women and taking a medical history is going to run across a woman who had a thrombophlebitis when on the pill or had a pulmonary embolus on the pill. Why take estrogen orally? This does not occur when you take it transdermally, when you apply it to your skin.
Right.
So I would pause, and if you have access to a healthcare provider that has taken on the study of bioidentical hormones, you better be treated with topical, and biased is best. So,
and I agree. So you can.
Yeah, oral estrogen, not a fan.
Yeah.
But if it was the only tool I had, I'd love it. I'd embrace it. I think it'd be great. So let's see. It's time for me to complete for today. We apologize for the technical technical issues that arose today, and I'm sure the internet will heal itself.
I think the women.
Whatever phase along the line led to us not being able to hear Carolyn today. All right, everybody, I'm going to sign off and see you in 2 weeks.
Right. I think you guys can hear me. I apologize. Thank you. Thank you. And this is a little crazy. We've never done it like this for sure, but we'll be back with you in 2 weeks. This will be fixed.
Bye-bye,
and all
everybody.
will be well. Bye, Dr.